since I've transitioned to Yale, really my passions have been in GI oncology and trying to get a better understanding of various biomarkers, whether it be radiomics, circulating tumor DNA, genomics, and how to incorporate that into the risk stratification to help better tailor and risk stratify patients for appropriate care. And much of my work has been in colorectal cancer, but I also have a lot of passion in pancreas cancer and upper GI cancers. So I'm happy to be here to discuss some of this interesting work.
Okay.
Thank you very much. Ahead, do you mind sharing a little bit more about yourselves with me?
Yes, yes. So Debbie, do you want to start or you want me to start?
I can start if you want.
Yeah.
I'm interested in this area because I'm a breast cancer survivor. I was diagnosed in 2010 with triple negative breast cancer, but I also was diagnosed with the BRCA1 mutation. And since I was really young, when I started doing colonoscopies when I was 35, because I had some polyps. So I've been following up all the time and everything. My grandfather also died of colon cancer. So really it's in my family. And even though I haven't had any other cancer diagnostic, anyways, I'm really interested in knowing a little more because I may need to know more because of my predisposition. And also I'm interested because I give support to other members in our area. I live in South Florida. And also I want to make sure that I can help them if they're diagnosed with colon cancer or upper GI or something related to the cancers that we are going to describe. So thank you so much. I want to learn more.
That's great.
Yeah, so I'll say something about me. I'm a stage 3B rectal cancer survivor. And, I did not have radiation because my tumor was high up in the rectum and under the peritoneal reflection. So it was treated more like colon cancer. I work with a colorectal cancer support group called Colontown. So we have a community called Rectalburg. We have over 600 rectal cancer patients there, all stages. And I'm also a patient advocate at the NCI Rectal Anal Task Force. So I get to know about all the trials that are coming up, and I try to attend the colon task force one also, and then see if I can get invited to the NRG meetings and CCTG, all of them. That's what I do. And I'm really interested in helping with trial design. That's what I'm really interested in. And then I used to be a cancer researcher. I'm a veterinarian by training, and but it's been a long time since I've done research. So now I work more on the administrative side, and I really like to translate complicated things for patients. And that's really what I like.
I'm an accountant by training, so really for me this is very difficult. But I went to project lead. I did many of the training that they were required. So now I can understand just a little tiny. And really my purpose is to help researchers and also help patients.
Okay. So do you want to start with the poster then?
Yes. So I haven't done this before.
Yeah.
How would you like me to pull up a poster and share my screen?
Yeah, that would be great.
Oh, great. So let me.
Yeah, don't worry about it. We haven't done it either. So
we'll just. Yeah, I've done it, but with breast cancer. So really it's just for you to give us an overview and see what you see, and then we can ask you questions, because for sure we are going to see things that we don't understand, and you can go over and explain them a little more in detail.
Okay, so I'm going to pull up. I don't actually have the OPRA trial poster, but I have their slides that I can share.
Yeah, that should be fine. Yeah, thank you for agreeing to do this.
Yeah, it should be fun.
Yeah.
It is. At the end, you're going to say it's worthwhile because you're going to listen our perspective and we are going to listen your perspective, and really makes a difference at the end of the day.
Yeah. So I'm not sure if you know Nina Sanford. Do you know her?
I do,
She's
yep.
yeah. So she did a session with us in the morning. So, and there were so many questions about proton beam therapy and all of that. And then so finally I made her agree to give a talk in Colon Town on, you know, radiation therapy for metastatic colorectal cancer. So,
Yeah, that's great. I just gave a talk to our group last week on proton therapy for GI.
oh, nice.
So the premise behind this study is, so it's called the OPRA trial, and that's stands for organ preservation for rectal adenocarcinoma. And just to provide a little bit of background on what this study was designed for, the standard of care for rectal cancers when it has not spread elsewhere in the body typically involves surgery. And that's been the standard of care for decades. We've built upon that such that we now give typically radiation therapy and or chemotherapy prior to the operation, because it helps a surgeon achieve negative margins a bit more effectively. And even more so than that, it helps improve the control of the cancer and perhaps the survival from rectal cancer. But one of the challenges with that approach is that surgery does have morbidity that comes along with it. Specifically, surgery for patients who have a cancer that's very close to the anus, so very close to the opening. And we have historically defined that as within 5 centimeters of the anus is typically a low rectal cancer. And why is that particularly challenging? Well, it's because when a surgeon tries to remove the cancer, they try to get negative margins. And often we like to have at least 1 to 2 centimeter margin on the tumor. And that can make where they cut very close to the anus. And then they have to take a piece of colon and directly stitch it back onto the anus so that patients can live their life without a colostomy bag. An inevitable consequence of doing that when they remove so much of the rectum is that patients can face fairly considerable side effects. They can lose bowel control. They can have tremendous urgency, meaning when they have to go, they have to race to the bathroom. They can have trouble discerning, are they going to pass gas or is it actually going to be a bowel movement? And that can lead to accidents. And that, you know, not only from a physical perspective, can really play its toll emotionally and socially upon patients. So with a real patient-focused quality of life perspective, we begin to ask the question, well, can we spare some of these patients from having to have an operation? And Dr. Haber-Gama, she's a surgeon from Brazil, has been a real tremendous advocate and amazing pioneer in the field to try to bring this concept of preserving patients from having to have surgery to the forefront of care for patients. And she faced heavy criticism initially when she presented this, and through tremendous advocacy and perseverance, she's helped pioneer this field. So I'm really excited to present this work, because she's, in part because I have so much admiration and respect for what she's done for the field. So this
What is her name? What is her name?
Angelita Haber-Gama, HABR-GAMA.
Yeah, like if you're registered and for ASCO, she was at the meeting. I mean, I heard she was 90 years old, and she was so sharp. So you can watch the sessions because it is recorded and available.
Okay, I'll watch it because it's
wonderful. So based upon that premise I just described, we've been looking at using radiation therapy and chemotherapy and assessing how patients respond to the treatment. And in those who have had a good response, not going ahead with an operation and seeing if we can spare people from surgery without any adverse effect on cancer control. So one of the challenges with this is that it's very challenging to select the best candidates for this approach. And the typical way that we do it is that we treat the patients with radiation therapy and chemotherapy, and then we perform subsequent colonoscopies or endoscopies, rectal exams, usually with a finger exam in the rectum, and MRI. One of the questions that we've had is, how should we appropriately sequence the treatment? Should we give chemotherapy first? Should we give radiation therapy first? And that was the purpose of this study. It was to determine the optimal sequence of giving radiation therapy and chemotherapy with the goal of preserving patients from undergoing surgery. That data was presented at the GI ASCO meeting about 6 months ago. And this is a secondary analysis looking at a 3-tiered clinical response assessment. Anyone have any questions so far? Great. So the methods were they looked at patients with rectal cancers. So these are tumors within the pelvis. They all had to be adenocarcinoma, which is the most common type of rectal cancer. It's also the most common type of breast cancer. And patients had to have stage 2 or stage 3 disease, meaning there was no sign of cancer spreading elsewhere in the body. Patients could have lymph nodes involved or not. And patients were randomized, basically a coin flip, to receiving either chemotherapy after radiation treatment or chemotherapy before radiation treatment. Then patients were assessed with the MRI, colonoscopy, and physical exam about 8 weeks later. And then they were stratified into 3 groups. There was the group that had a clinical complete response, which they defined as a flat white scar, telangiectasia, which are these small red blood vessels that you see. That's a typical finding that we see after radiation treatment. No evidence of ulceration or nodularity, and the exam was normal. On the opposite end of the spectrum was incomplete clinical response, meaning there was still visible tumor and there were nodules still palpable, or they could feel them on the exam. Patients who had a clinical complete response were recommended not to have an operation, but to continue the very close follow-up. And those who had an incomplete response were recommended to undergo standard surgery for a rectal cancer. And then there's this group in the middle that is very challenging for clinicians to determine what to do with, because we know some of those patients, if we watch them long enough, will then ultimately develop a clinical complete response, whereas some of those patients, the cancer will eventually progress. And so it's challenging for us to know, should we continue to watch and wait, or should we recommend that they go ahead with the operation? So when we look at the groups included on this study, there was actually fairly well-balanced stratification between the 2 arms of the study, that was induction chemotherapy versus consolidation chemotherapy. And we looked at pathologic complete responses, or excuse me, clinical complete responses. It was actually a little bit better in the group that initially had radiation therapy as opposed to having chemotherapy first. Here, the proportions that are being reported are actually amongst each clinical stratification tiered group, response group. They are not being reported as treatment group. So of those who had a clinical complete response, about 56% of patients received their radiation therapy first, 44% had their radiation therapy afterwards. If you look at near complete response, it was about 50-50 split. Or if they had an incomplete response, it was about 50-50 split. And there was no difference between groups here. And then when you look at maximal or median tumor distance from the anal verge, it was about the same, about 4 centimeters, 4.5 centimeters. If you look at sex, about 60 to 70% were male. That was not statistically different. If you look at median age, most patients were 50 to 60. And then if you look at the extent of tumor within the rectum, you see most patients had T3 disease, meaning the cancer had spread outside of the wall of the rectum. When we talk about T1 or T2 disease, that means the cancer is still confined to the innermost layer of the rectum or the middle layer of the rectal wall. And T4 disease means the cancer has invaded other organs, which in men would be organs like the prostate or the bladder. In women, that would typically be like the vagina or the uterus. Sometimes it may invade backwards to like the sacrum or the bones of the pelvis. Then if you look at the nodal stage, over half of patients had node positive disease. And I want to pause here and just mention, we're looking at patients with mostly T3 and mostly node positive disease. So I say that with purpose, and that means these are not only patients with early stage rectal cancers. These are, a fairly kind of medium risk group of rectal cancers. It's a very common group that we see. So it's not like we're selecting for the most favorable group here. In other words, this is likely an applicable strategy for many patients with rectal cancer.
And Krishan, I had a question. So with the T4, it can also mean just tumor in the perirectal fat, right? Without invading into neighboring organs.
Tumor in the perirectal fat is still T3 by definition. We've stratified that even further. There's actually a T3A, T3B, and T3C, which is an MRI defined criteria, defining it as how far outside of the rectal wall into the fat it actually spreads. But that's a very good question. They didn't provide that degree of granularity when they defined it in this paper, in their presentation. I would love to see that data in the eventual paper.
The reason I ask is, when compared to colon cancer, the staging is a little bit more complicated in rectal because it's all MRI staging, and there's difference between what you see on a CT, what the surgeon finds with or the GI doctor finds on colonoscopy, and then, the MRI, right? So we have people in the group who say that their doctors are not in agreement, how their tumors are, how far from the anal verge. So that's why I was asking.
Yeah, that's such a great question. And there will be differences in the measurement from the anal verge based upon comparison of MRI or flexible sigmoidoscopy or rigid proctoscopy. There will always be differences in that measurement. And at least in my practice, I use physical exam, digital rectal exam as my greatest determinant of distance from the anal verge. And I think probably second best or arguably best is rigid proctoscopy. But that does have some discomfort for patients to undergo that procedure though. Usually done in the operating room under some anesthesia.
Okay. And I feel that in the end, it doesn't really matter because nothing much is going to be so different based on whether it's half a centimeter this side or that side, right?
I agree completely.
Yeah.
Yep.
I have a question. When you said that you do this treatment, the chemo first and radiation, when you have the category, the one in the middle that is the near complete response, can you continue the treatment before deciding to do surgery? Or there is a limitation on how much chemo, because for example, for breast cancer, you can continue with another chemo, another radiation. So does it apply here too?
Yes and no. That's a very good question. It's one that we struggle with. So, and I say yes and no only because giving more chemo also has side effects, and giving more radiation therapy also has side effects. And we do not necessarily know that giving that extra treatment would then prevent a patient from having to undergo a surgery. As we'll see in the coming slides, we know that after giving both radiation therapy and chemotherapy, the near complete response is prognostic, meaning it is suggestive of ultimate outcome, but it doesn't tell us if further intervention would change that ultimate outcome. So at least in my practice, I am pretty apprehensive about giving extra treatment when something is prognostic and doesn't indicate if further treatment would be helpful. Because as you both know far better than I do, the side effects of chemotherapy like neuropathy, hair loss, fatigue, nausea, they all take their toll on patients.
That's right. One more question. How representative is this study? Because I see very small sample size, like 200 people, 200 and something people. Is this really representative, or further studies have to be done?
Further studies have to be done. This is what we call a phase 2 study. The vast majority of patients were enrolled at Memorial Sloan Kettering Cancer Center, so a single institution. So not necessarily extrapolable to the rest of the world, rest of the population. But one thing I do want to share is that rectal cancer studies will almost always be smaller than breast cancer trials. And that's in part because breast cancer is far more common than rectal cancer. In the US, there's about 40,000 rectal cancers per year. In comparison to breast cancer, about 200 to 250,000 breast cancers per year. And the other difference on the clinical trial side of things is that the endpoint of interest, whether it be overall survival, disease-free survival, or local control, the incidence rates of the endpoint, disease progression or death, are higher in rectal cancer than they are for breast cancer. Meaning, if you look at a heterogeneous group of all comers, rectal cancer tends to be a more fatal cancer than breast cancer. So I say that because if you have a breast cancer study, the event rates are small, which means you need to have many, many, many patients on the trial to see a statistically significant endpoint. So
thank you so much for those numbers, because I was thinking that like now with, the screening guidelines, the age being reduced, maybe hopefully more people with cancer will be diagnosed, right? And I mean, 40,000 versus 200,000 is like a huge difference.
Yeah.
Numbers. Yeah.
Any other questions?
For now, we're doing great. Thank you. You explained it really well. Thank you.
You do an excellent job.
Yes.
Oh, thanks so much. So the median time to assessment here was about the same in both treatment groups. And when I say treatment groups, I mean induction versus concurrent therapy. But also when you look at complete response, near complete, and incomplete, again, about the same in each of these cohorts. And that's important because if they were different, there's a key difference that you'd want to see. It would be that those with a clinical complete response, if they had longer interval after treatment than the other groups, then a big argument would be, well, you didn't wait long enough. That's why there wasn't a complete response yet. So it's important that we see this being the same. And then if you look at treatment recommendation after assessment, it basically follows what we would expect. Those who have a clinical complete response, 98% were recommended watchful waiting. And if you look at incomplete response, 85% were recommended to have an operation. And then I find this interesting, at least in their practice, those who had a near complete response, 82% were recommended not to have surgery. Which is actually different than what was recommended during the discussion that Dr. Habergam was on. There was a little bit of difference in the panel recommendations. And that reflects, quite honestly, that reflects pretty accurately how these patients are often managed throughout the country.
And I think that like maybe if you're at a place where they have a lot of experience with watch and wait, they are willing to take more chance, right? Because
that's the key, I think, comfort. Yeah. So these are the outcomes. If you look at each of the groups, and you'll see either orange here is clinical complete response, green is near complete response, and blue is incomplete response. This is surgery-free probability. And you see that those who have a clinical complete response, 78% were spared having an operation, which is really quite amazing. Close to, 4 out of 5 patients didn't have to have surgery. and be met with the side effects of having an operation for what is usually a low rectal cancer. And then even more interesting, I think, is that those with a near complete response, we spared surgery in almost half of patients. Then if you look at local recurrence-free survival, you see a p-value here, which is statistically significant, indicating that there was a difference between these three groups. And the difference seems most striking for those with an incomplete response. More had a local recurrence compared to those in the other two cohorts. Similarly, disease-free survival, it's statistically significant. We see that the first two cohorts do reasonably well. Near complete responses do a bit worse. That's, I think, an indication of the biology of the disease. And those who have an incomplete response have a considerably worsened disease-free survival, again, indicative of the biology of their disease. That this essentially means that if you don't have a complete response at the primary tumor after both chemotherapy and radiation, that you have a tumor that's less responsive to our best known therapies for this disease. And that indicates poorer biology that we really need to understand better to help patients. And then that's also reflected in metastasis-free survival. Those who have complete response or near complete response have a lower risk of metastasis of their cancer, whereas those with incomplete response have a higher risk of metastasis. So their conclusions were that the three-tiered clinical response assessment schema based upon endoscopy, rectal exam, and MRI has prognostic, that's the key term, prognostic implications. It's indicative of outcome, but doesn't tell us if we should treat patients differently. With the expanded watch and wait eligibility, meaning allowing patients with a near complete response to be eligible, almost half of those patients with a near complete response achieved organ preservation, and close to 80% with a clinical complete response achieved organ preservation. Mm-hmm. And while the treatment impact cannot be included, the survival differences between response groups does point to some biological distinctions, which I was trying to emphasize. So that's the study. I think it's incredibly interesting. It's something that I've been discussing with our group here at Yale, and I gave a talk to some colleagues at Mayo Clinic about this exact pathway a few months ago, because I think there's a lot of ways that we can try to improve our risk stratification and selection of patients, and I think this is a really opportune time to design a trial building upon this.
Yeah.
But I'm curious to hear both of your thoughts on this study.
Yeah, this is they have the Janus trial, the next one. So we actually I helped with the trial design because watch and wait is something that is of great interest to people, especially with rectal cancer rates going up now in the younger population. If there was a way to avoid an ostomy, a lot of people would prefer that. So that way, this was really attractive to patients. So I think for me, the things would be that, following like chemoradiation and chemo, those people who had the rectum preserved, how was their quality of life? Did the radiation have any effect? Was it almost close to normal rectal function? I'd be curious about that. And long term, like what was their feelings about it? Because I know that we have a bunch of people who are on watch and wait, and it's like I feel that like they are so hopeful that they can avoid surgery, but then when they have the rectal exam and to find out how they've responded to treatment, and they come to know that it's not a complete response and that their team is now thinking that they might need surgery, that becomes a big letdown for them, because till then they were really hoping that they'd be the ones who would not have surgery, and then that becomes a big disappointment. So in our group, we really try to tell people that don't think about it as non-operative management, just think about it as surgery later. Whether you have it like in 6 weeks or in a year, then you're thinking that like maybe you can escape having surgery, but maybe you may not. So you're not feeling so disappointed if, due to whatever reason, your tumor is not responding as everyone thought it would. So
that's a really interesting perspective, and it's one I haven't necessarily thought of. The terminology physicians use in describing a pathway of care, and the kind of the emotional impact of that.
Yeah, we
The
have had
words really matter. Yeah.
Yeah, we have had, I mean, it's not their fault, right? Like, because they are so hopeful to avoid surgery, and then, and I mean, what do you say? Like, you can't say, well, it's good because now if you had not, if, for example, you didn't have surgery and it grew again, then at that time you would have to have surgery, and the chance of, distant spread is higher if you let that tumor stay, right? So it's very hard to console patients at that point. I mean, and most of them, they do have surgery and they're okay, but that period is like a big letdown.
I'm sure it is.
Yeah. So I mean, especially what I suggest is like if the clinicians introduce it as not completely, the chance of not having surgery, but to say that it's likely that you may not need surgery now, then patients are not like, it's just a few words, but they are not having that kind of a letdown when it doesn't work out.
It's all about managing expectation.
Yeah.
And it opens the idea of, well, this is kind of a long-term watching situation, and it's possible or perhaps likely that surgery may be indicated in the future. So it's
and the patients, they think also, I could have done something, or so they feel let down just because they tried everything and they couldn't succeed. But it's really nothing that they can do. They follow your advice, but your advice has to be clear. So I think that the emotional part is very important.
Definitely. Now Manju, you mentioned a really good comment earlier about what is the quality of life after watch and wait compared to surgery. Those data haven't been well presented to date. And I know they were included in the OPRA trial. Dr. Smith, who's been a real advocate in this arena, gave us a talk recently, and he did share that quality of life assessments are planned to be reported as part of the OPRA trial. I haven't seen those data yet, but I would love to see them. But I can speak to what quality of life would be after a patient who receives pelvic radiation, for whether it be a rectal cancer or an anal cancer. There are a few pretty common side effects that happen. In fact, they're almost universal. There are changes in bowel function after. Most patients, the medical term we use is a phenomenon called clustering, which means, if an average patient before any treatment has one bowel movement a day, and let's say they're pretty regular and it's always in the morning, many after they receive pelvic radiation have this phenomenon where they may have their one bowel movement in the morning, but it's rapidly followed by like 2 or 3 or 4 small urgent episodes of having to, the feeling of having to have a bowel movement. And then they may be fine the rest of the day. And we call it clustering because they cluster around this period of time a day that they have multiple bowel movements. That is one of the most common side effects after pelvic radiation. Some of the others include incontinence can happen, especially if it's very close. The cancer is very close to the anus, or the anus gets high doses of radiation. It's not particularly common, but it can happen. More common than that is the loss of ability to discern, is it gas or are they actually going to pass a bowel movement? And that has tremendous emotional implications on a patient, because it can be, embarrassing if you're out in public and something like that happens. So
and that is more related to age, sex, or everybody has the same side effect of radiation?
They're varying severities, but these are often, if you ask pointed questions or use a sensitive enough quality of life survey, most patients will report some of these side effects.
Okay.
Yeah, I'm happy to hear you mention clustering, because this is the first time I probably heard a clinician use that word, because in our groups, it's very commonly used. And I want to say that like I had a low anterior resection surgery and I had clustering after that. And, like if somebody had told me before what clustering was, I wouldn't have believed it. It's something you have to experience to know. So I'm glad that like, we call it like low anterior resection syndrome, in that
Yeah.
clustering is part of it. So I'm glad to hear you use that word, because usually it's the patients who are using that word, and I haven't heard that from clinicians yet.
Oh, yeah. I try to teach my residents about this, to ask, because I mean, quite frankly, if you ask all patients who come in for follow-up, they all have clustering. It's so incredibly common.
Yeah. The other thing that we talk about is vaginal stenosis in women.
Yeah, that's what I was just going to talk about. And it's so frustrating to me, because it's something that we can take actions to help. But there have been surveys that have put out querying GI radiation oncologists or other GI oncologists, what proportion of them talk with women about sexual health, or even men about sexual health after pelvic radiation. And it's sad to see it, but a pretty large proportion, it's never discussed. Whereas if you ask gynecologic radiation oncologists, it's pretty much universal that they have these discussions about sexual health. And that also has tremendous emotional and social impact on patients, and can put a lot of strain on their intimate relationships with their spouses or significant others.
Mhm.
Yeah.
So that
On the emotional part, like with more diagnosis in the younger population, many people are, they are left having conflicting emotions, because they feel that they should be happy that they're alive and, okay with, missing some aspects of their life, but that's not fair, right? It's often that when they come to our groups is when they realize that they could have done something and they were not told, and that becomes very difficult to handle.
Yeah, I can understand that. So in your groups, what types of things have been shared that patients wished they would have known, or actions they wished they would have taken?
Yeah, these are the kind of things. So we have, so I actually get many people to talk. Like, so we had Dr. Sharon Bauber. She's a health, sexual health person. So she had come and given a talk. So in our groups in general, yeah, sexual health is something that people talk about. The other thing is about, when they have surgery for rectal cancer, they really don't understand the consequences of it. Like that, what does it mean to have an ostomy, and how your life is going to change? Like at the time when you're diagnosed and you're meeting the doctor, and you're, especially for rectal cancer, you have to meet a surgeon, an oncologist, a radiation oncologist. And, for most people, it's grappling with the fact that they have cancer. So in between all of them, all of this, when they're told all these different things, they don't really, they understand the words and all of that, but they don't really get the implications of how their life is going to change. And I feel that that's the biggest thing that we see. And, and I think that, like, I don't know what's a good balance, because if you tell them everything you're going to get, they're probably going to be terrified. And it's not, it's not that everyone will get all of that, right? So what we have suggested is, like, if the different clinics could make a video testimonial from people, throughout the spectrum of all the side effects, people who are young with an ostomy, who go skydiving, and people, who had low anterior resection syndrome and are homebound, and just talk about all possible things. And then when you're explaining to the patient, you could tell them that this is the spectrum, but this is the common things that we see, and you may not experience all of it. So that way they are more mentally prepared.
Sure.
I have just one more question regarding radiation. Is that as what happened in the last few years? It advanced as much as in breast cancer. Before they would radiate the whole chest wall. Now it's really targeted. That happens the same for colon cancer or rectal cancer. How is it?
Yeah, good question. So the colon cancer question is an easy one to answer, in that radiation therapy is not typically used for colon cancer. There are very, very select circumstances that it is, but those are highly, highly select. For rectal cancer, we've done quite a bit of work to improve the techniques of radiation therapy. But interestingly, the techniques of radiation therapy that have really improved drastically over the decades, those include techniques something that we call intensity modulated radiation therapy, which essentially means using advanced computer-based planning techniques and many radiation beams to make the high dose regions of radiation specific to the tumor. And even more recently, proton therapy, which is even more specific to the tumor and has less radiation exposure to normal organs like genitalia, bladder, bowel. We don't have randomized trials to support IMRT or proton therapy for rectal cancer. We did do a randomized study, or we did do a prospective study looking at IMRT for rectal cancer. Mm-hmm. And that study did not show a significant improvement compared to a historical group of patients.
Well, but at least the side effects, maybe they're diminished, maybe there are some advantages for the patients. I imagine that with the new techniques, there are advantages.
So you're preaching to the choir. I'm a proton therapy believer. I can show you what a proton therapy plan will look like for rectal cancer. If you give me one moment.
Yeah, because now they install it here. I live in South Florida in Baptist Hospital, Miami Cancer Institute. They have proton therapy, and they explain that it can be used also for breast cancer. And really, it's fantastic because of the less side effects and everything that has this technique, right? I don't know if it's a technique or a technology, or I'm not sure how to qualify.
Well, a little bit of both.
Okay.
Yeah, I heard that, like, where the field has to be a little bit wider, maybe it's better to use the regular beam than proton. So I'm kind of curious.
Yeah, so these are 3 plans. So this is from a paper that a tremendous colleague, Elizabeth Jeans, and I wrote. So this is the standard radiation field for rectal cancer. If you're looking at the scan, these are CAT scans. These top 3 are the standard treatment for rectal cancer. It's called 3D conformal radiation therapy. That's the standard technique. That's also the standard technique used for breast cancer. This middle technique is a kind of a fancier method of radiation delivery called IMRT. That's the technique that uses computer-based technology to make the high dose regions of radiation more specific to the tumor. And on the bottom, this is proton therapy. All of these patients got what we call short course radiation, which means 5 treatments over 1 week. And this is a comparison of the plans. On each of these plans, the red indicates the high doses of radiation, green indicates medium doses of radiation, and blue is low doses of radiation. So what I want you to look at is these slides, or these images on the right. This is 3D conformal. And you notice this blue, that's the kind of low, and green being intermediate doses of radiation. You see they go in from the back of the patient and they go all the way through.
Mm-hmm. And that would be the kidneys and everything else that is in the back, right?
Well, thankfully the kidneys are above this.
Oh, okay.
But if this was radiating an area of the belly, it could have dose to the kidneys. But this is the major downside of standard X-rays or photons, is that the X-rays enter the body, they deposit their radiation, and they continue passing through the rest of the body, depositing radiation. For rectal cancer, as you probably see in the slide, we use typically 3 radiation fields, 1 from the left side of the patient, 1 from the right side of the patient, and one from the back. And so you see this kind of medium and high doses coming out from the sides. And then the blue is the low dose coming out at the front. This is IMRT. And you notice with this plan, that blue and green is kind of tucked in a little bit. It's sucked in a little bit closer to the back of the patient. This is the tailbone right here. And this is the rectum right in front of the tailbone. So you'll see that this red is pulled in a little bit closer to the tailbone, as is the green, as is the blue. So that's IMRT. But as you all probably have a very keen eye, this blue is still pretty much going out the front. And if you look at it on this image, this blue treats most of the bladder on this slice. You have a lot of bowel. This kind of light gray here is bowel. And so even with IMRT, there's a fair amount of radiation exposure going to bowel. And then this is proton therapy. And, I look at these and this makes me all excited because that distribution of radiation dose is beautiful. It's hitting the tumor and sparing almost all of the normal tissues. This is the blue, which was that low dose of radiation. You may not see there's a red line here. That's the actual target of where we want the radiation to go. And this blue is very conformal, very tight to where we want the radiation dose to go. And the bladder right here is almost entirely spared, and the bowel is almost entirely spared. So one would argue, or theory would support, that proton therapy would have a lower risk of side effects. We do not have a randomized trial for rectal cancer as of yet. It's actually not been reported. We don't have a single one reported to show that proton therapy is helpful.
Is it more expensive? What is the hesitation?
That's a good question. Actually, not so much. So this is the work that I'm trying to get published and working on. Is interesting. If you look at, and this paper that we have comments about the financial burden of proton therapy as well. If you look at a 5 treatment radiation course, so short course, and compare that to 5 treatments of IMRT, which is this technique, and 5 treatments of 3D conformal radiation therapy, the cost is almost identical. If you do standard radiation, which is like 25 to 28 treatments over 5 to 5.5 weeks, then proton therapy is a fair amount more expensive, as is IMRT.
What I've seen here in South Florida, at least, is when patients, they're proposed to get the proton therapy, the insurance is the one that doesn't approve it because it's more expensive. Because they said, go for the other type of, if they don't have a very good insurance. So this is where we as patients, we have to start fighting also the insurance companies, that if this has less side effects and everything, we should be using proton therapy.
Sadly, that is also the case in this situation. I'd be interested in getting a copy of your paper.
Sure.
This would be, yeah, and I was wondering that argument about, the surrounding tissue not getting radiated. I was wondering with proton therapy, you can probably do focused, a little bit higher dose on certain areas, right?
You can do that. Yep. You can do that with IMRT. You can do it with proton therapy. And you can also do it with a technique called brachytherapy, which is inserting a radiation device actually into the patient. But those also, these advanced techniques do provide a nice research perspective in that you can, repeat these questions of, does more radiation dose benefit a patient? And you may be able to do it more safely than you could with the previous techniques, because you can spare more normal tissues the harmful effects.
This is
I think
fun.
that, like, for patients, when you, in general, like when you ask them, would you have more radiation versus more chemotherapy? Everybody's scared of radiation more because they feel that the chemotherapy, it's just the time they're getting chemo and after that it's gone, With the radiation, they're worried that the side effects are going to be permanent and long lasting. So in those kind of studies, the proton beam therapy, that might be like make them less anxious about right?
Certainly. And those are the things that bother me too. I mean, I enjoy caring for patients, but something that's always on my mind is, in this patient, hopefully we can cure them, and how is their life going to be, not tomorrow, but 5 years from now, and 10 years from now, and hopefully 20 years from now, especially with some of these young patients that we're now seeing.
So if you have any projects that you're working on and you want like a patient, like for example, you do a survey and ask them, if the cost is same and you're doing short course and you have the option of a proton beam, how many patients would prefer to have proton beam therapy? If what the patients say can sway the review committee or something, I mean, feel free to reach out to us. We'll be happy to do the surveys.
Yeah, that sounds wonderful. Any other questions about proton therapy?
Oh no, it was really very, very informative. This, and to see it in pictures is perfect.
Yeah,
Wonderful.
I think we'll have to invite you to talk about proton therapy now.
Yeah, I'd be happy to. I just gave this talk last week, actually.
I'm going to take a picture of this, if you don't mind.
Yeah, please go ahead.
There you go. Thank you.
Yeah, I'm recording it, so I can give you a copy. I can email you one so you can see all of it. Yeah.
So I think that the next questions regarding the OPRA trial is where do we go from here? And I think there's a lot of next steps to that work. One of which I think we need a randomized study to help provide more guidance on it. It's going to be the hardest study to randomize. It's almost impossible. And I say that because we've tried to do, this is essentially a randomized study of, we have a clinical complete response, and we're going to say half the patients have surgery and half the patients don't have surgery. Mm-hmm. And then we're going to have to say, oh, and guess what? The computer is going to tell you which treatment you're going to get. And every patient's going to look at us doctors and say, are you insane? Yeah. You think I'm going to let a computer tell me if I have to have surgery or not? So,
but see, the other thing is that in our groups, it's interesting. You would think that if people have the option of avoiding surgery, that a lot of people would jump to it. Actually, there are a bunch of people who would rather have the thing out of their body, and they are happy to live with it, but they just want to know that, get it out. They don't. Yeah. So, I mean, those kind of people probably want, like, they don't really want to know whether they have a complete clinical response or not. They were like, tell me when this damn thing will be out of my body. Right? That's all they want to know.
Yeah, and we've tried this for other types of cancers already. We've tried to do these randomized trials for prostate cancer, surgery versus radiation. All of the studies, they couldn't accrue in the US. Finally, as of about 4 years ago, a study out of the United Kingdom was published that finally did it. In the US, we tried to do randomized studies of surgery versus radiation therapy for early stage lung cancer. They didn't accrue at all because no patients were willing to do it. We now have that same trial being done through the VA health system, and that's actually is accruing, but it's a very challenging randomization. And then we also had the same challenges with like head and neck cancers, surgery versus radiation. The trials just didn't accrue. Ultimately, it was the VA health system for larynx cancer that helped us with that too. So it kind of depends upon the healthcare system and the patient population and their willingness.
And then maybe you should do a 2:1 randomization or something, and tell them that you have higher chances of avoiding surgery, or, I mean.
Yeah, there you go.
Yeah, so I don't know what's the right answer.
Yeah, so it's challenging. And then the other ways I think we can build upon this data is incorporating novel mechanisms of response assessment. And I think some of the most exciting work is circulating tumor DNA. There has been work on that. I think there's also ways that we can use radiomics. Radiomics, what that means is that, you know, the human eye, when it looks at imaging like MRIs or CT scans, we can only see so much. You know, we're good, but we're not perfect. But we can use advanced computer-based technology to take thousands and thousands of MRIs of patients with rectal cancer and see how things change over the course of treatment. And those computers can pick up patterns that the human eye can't see. And radiomics may be able to tell us more effectively which patients have a clinical complete response or what their prognosis may be based upon radiomic findings.
That'd be cool.
And then the other way I think we can build on this data is using tumor genomics. So I think we've pretty nicely established that a P53 mutation in a rectal cancer has some degree of radio resistance, and KRAS mutation in rectal cancer also has some degree of radio resistance. The two combined together makes for a somewhat radio resistant phenotype. So if we knew beforehand that a patient had both of those mutations, we may argue that, oh, that patient might not be the most ideal for a radiation therapy approach for organ conservation.
That's kind of interesting to know.
Yeah, so these are kind of the things that I've been kind of tossing around in my mind, trying to think of a way to build a kind of a next step clinical trial for organ conservation, or I guess surgery later approach.
Nice.
Yeah, like the other thing is that, you know, for early stage patients, there isn't much tumor testing done, right? Right now, they only know the MMR status and maybe BRAF. Nothing else is being done. So, I mean, I think that once tumor testing becomes more standard for everyone, then that will be like a lot helpful, right? At least, you know, if KRAS and P53 are the ones that, you know, you can have like a 10 gene panel, right? Like you don't need to do, I don't know, 300 alleles or something. But, you know, that would be really helpful. And I wish that those companies would, you know, do that. And, you know, if it's like $200 or something, and then the insurance would cover, that is more practical, right?
Yeah, I agree. The last study that I helped work on for this, we used research funding and had it all paid for. And fortunately, we used 50 gene panels, and it was all done within our institution. So it was easier for research purposes, but for all patients.
Yeah, you need to work with the company, and out of the 50 gene panel, you probably know which 15 are the most important, right? And you could easily make a rectal cancer panel to tell people whether their tumors will be radio sensitive. I mean, it'd be great if things work like that.
Yeah, there's a lot of work on that. I think it's very exciting.
Yeah. Do we have time for the other poster?
I think we do. This is also, I think, an interesting poster. So let me find it.
Yeah, we have to invite you to Colin Town. This is great. You have a
I'd love
great way of explaining.
Fantastic. I don't know anything, and now I know a lot.
Oh, that's great.
So really, you made my day.
Yeah, I'm so glad this is being recorded, because I'm sure that, you know, I don't know if you want to share your email, because I'm sure that a lot of people are going to ask questions.
Sure, I'd be happy to.
Yeah, I think that this would be a good teaser to tell them that, you know, you're coming back to Colin Town. So.
So I have the abstract.
Okay. What was the number? I can see if I can pull it up.
Let's see.
I think that is the 336917, right?
It must be on the GRASP site. Let me see.
Yeah.
It was the immunotherapy one.
Yes, the Pandora trial. Yeah.
Mm-hmm.
See, I think we have many, what is it, repeats. So, I think it's a relatively simple one. 3, 6, 8, 7.
Oh, here we go. I got it.
Oh, you got it. Okay.
Yes.
So is this useful to you? Are you finding this fun?
Yeah, I do find it fun. I love hearing patient perspective. Part of what got me interested in quality of life is that when I was a resident, my dad was diagnosed with AML, and he experienced such tremendous side effects from treatment, and he actually ultimately passed away from treatment-related complications, and he passed away within about 2 to 3 months of being diagnosed, and the end of his life was, I mean, it was quite frankly miserable. And it gave me added perspective on, you know, what patients go through during their treatment. And it taught me in part, if I were a patient, what I would want from my physician and how I would want to be talked to and how I would want information shared to me and the type of supportive care I would want if I were in that situation. And that tends to be on my mind when I chat with patients. And it's really been what I've tried to focus my research efforts on, improving the quality of life for patients as they go through therapy. Because I feel for patients as they go through this. It's challenging.
And the thing is that sadly, we can tell by interacting with clinicians, you know, who have direct experience with cancer and who don't, because there is a difference. So.
Yeah, I'm sure there is. I mean, I was pretty naive, I think, when I was a medical student and didn't understand it quite as well. And then you learn and it affects you. And I think you feel for your patients so much more as you go through the field more.
How long ago did your dad pass?
He passed away about 5 years ago, 6 years ago.
So sorry.
Yeah, thanks. Okay, are you able to see my screen?
Yeah.
Mm-hmm. Is it large enough? This poster doesn't. Oh, here we go.
Yeah.
Okay, so just as background, the standard of care for rectal cancer actually changed probably before this study was designed, and I mentioned that because we have to interpret that a bit as we go through this study. So the standard of care treatment, like I mentioned, for rectal cancer, it involves surgery as kind of the backbone of treatment, but we typically give both radiation treatment and chemotherapy before the operation to help improve the outcome. As with many types of cancers, we've been exploring this question of, does immunotherapy, medication to help improve your own body's immune system at fighting cancer, can we use that type of medicine in rectal cancer to also improve the outcomes? And so this study, if I zoom in here, looked at, are you able to see this? It's pretty small.
Yeah, kind of. Yeah.
Mm-hmm.
This should be okay. T3
Okay.
to T4.
So this looked at patients with T3 to 4 node negative or node positive rectal cancer. So somewhat similar to the OPRA trial that we just discussed. But there could not be any cancer spread elsewhere in the body. And they all had the standard staging studies, which included CAT scans, MRI, colonoscopy. And then patients did have genomic testing. There's a very important one on this list, which is the first one, which is mismatch repair deficient. There's a set of mutations or set of genes, proteins that are involved in repairing damage to DNA. And we know that there's a specific type of DNA injury that is indicative of immunotherapy response, and having a deficiency or mutation in that set of proteins indicates a very significant response to immunotherapy. Those types of proteins are the same proteins mutated in the syndrome called Lynch syndrome.
Mhm.
And then here are a set of other genomic tests that have some indication for prognosis. So these patients got this kind of the standard of care treatment for rectal cancer, which is combining radiation treatment with chemotherapy. The chemotherapy was a pill that we call capecitabine. They take it twice a day during radiation treatment. And then after completion of the radiation therapy, they got immunotherapy with a medication called durvalumab, which is one of many immunotherapies that are used in cancers to date. They got 3 infusions. Each was delivered over 3 weeks. And then they had surgery. And the question was, could it improve the outcomes? I did mention briefly that the standard of care has now changed. This is still a suitable approach, but it's not the approach that most centers have now adopted for advanced rectal cancers. We now also give chemotherapy, kind of full doses of extended chemotherapy before the operation as well. If we look at the types of patients included on this study, 68% were female. The median age was 63, but you see it, there was a 35-year-old patient included on this study. Most patients had a performance status of 0 or 1, meaning they were highly functional people that could carry on all activities of their life or the vast majority. And you notice 67% were palpable. This indicates that there were low rectal cancers. They could be felt by a finger. There were very low rectal cancers. And then if you look at the staging, most of them were T3 or T4. Most had lymph node involvement. And then here's another indicator of risk. It's called extramural venous invasion. That's kind of a complicated term, but what that basically means is that there's cancer inside the veins, and they're not the veins that are actually in the rectal wall. They're veins that have left the rectal wall inside the pelvis. That's a risk factor for disease spread and survival. And about 28% had extramural venous invasion. So the goal of this study was initially to accrue a small number of patients and see if there was an indication that there was good cancer killing effect when they went to surgery, meaning when they had the tumor removed surgically, was all of the cancer killed? We call that pathologic complete response. And the reporting on that first group of patients here, their goal was to include 55 total, but they're reporting on the first 20. So patients were accrued between November of 2019 through July of 2020. 20 patients were accrued, of which 19 were evaluable. And 18 of those patients ultimately underwent their surgery. And the surgery was done 13 weeks after they finished chemotherapy and radiation treatment. And if you look at the side effects of treatment, which we often call adverse events or AEs, grade 3 to 4 means they're serious adverse events, some of which could make a patient have to be hospitalized or have to take aggressive interventions to fix. Those were pretty low. Only 1 patient had grade 3 to 4 diarrhea. 2 patients had significant neutropenia. And then there were 8 patients who had relatively mild or moderate side effects. They did report the number of patients that had pathologic complete responses, and that was 5 patients of the initial 18. And so then I think the important question was, well, 5 of 18, is that what we would expect to see? Is that a high rate? Is that a low rate? On average, if you have a patient who gets chemotherapy and radiation and surgery about 8 weeks later, about 15 to 20% will have a pathologic complete response. So this is a fairly in line with that rate. It's just over 20%. And so they use these data to say, well, that met our stopping criteria. This was a suitable result. Let's continue on the study to finish the entire accrual and see what we learn.
I was kind of curious that they didn't tell us how many were MSI high.
Ah, that's the key question. You know this data so incredibly well. That is the question. Patients who, so the standard of care for metastatic colon or rectal cancer that is MSI high or microsatellite instability high, or another term, mismatch repair deficient, that this DMMR, the standard of care changed within about the past year and a half or so. It used to be chemotherapy. It's not chemotherapy alone anymore. It's either immunotherapy alone or the combination of immunotherapy and chemotherapy. But that is not the case for patients who are MSI low or mismatch repair proficient. The standard remains chemotherapy. That's because the response rates are not very high with immunotherapy. So really the key question here is, if you give immunotherapy to a patient that's mismatch repair deficient, what is the pathologic complete response going to be? Probably dramatically better.
Yeah, my other question was like, I heard that with rectal cancer, the MSI high rate is pretty low, right?
It is, unfortunately. Yeah, it is low.
Unless they selected patients.
Yeah, which is unfortunate that it's low. So there's a small minority of patients that can really derive the benefit of that.
But if they were MSS, then this would be awesome. That, you know, adding
completely
would be right.
Yeah, unfortunately, that's not the scenario. So I think there may be other indicators, because all of the assessments we've had to date are looking at mismatch repair deficient in the setting of systemic therapy for metastatic disease. And what we do know is that radiation therapy can change the environment around the tumor. We call that tumor microenvironment, and it can change the tumor itself. So radiation therapy in and of itself can be immunogenic. It can trigger immune response. So immunotherapy may be different in the context of radiation therapy than it is for metastatic disease. I think the other things we're trying to learn, this study used the immunotherapy after radiation therapy was complete, which is very, very different than another very key clinical trial that's been done with this paradigm. That's the NRG GI-002 trial, which had, and I mentioned that because you may hear criticism of the Pandora trial, and you may hear the criticism, oh, that's already been done. It's actually quite a bit different. The GI-002 trial gave chemotherapy first, the standard chemotherapy, which is FOLFOX. They gave 4 months of chemotherapy. Then they gave chemotherapy combined with radiation. And during the radiation treatment, they're adding different drugs to see if we can improve the response. There was an arm that used pembrolizumab, another immunotherapy combined with radiation treatment. Those results were presented at GI ASCO. And pembrolizumab also did not improve pathologic complete response compared to standard chemotherapy and radiation. In other words, that would be interpreted as a negative trial, not helpful. But like I said, this is a different study. Maybe we'll learn something more.
So you think it's a sequence that they didn't do chemo first and this was just combined with radiation that made a difference here?
Actually, I think we're going to see the same result in this trial as we did in GI-002. But I don't think they're perfectly the same. I don't think you can say GI-002 is a negative trial, so therefore this will also be a negative trial. I think there are enough differences where one may question that we'd have different findings.
I mean, I felt that like if for people, if this was just chemoradiation plus the immunotherapy, and they were getting this many, CCR, then, I mean, this would be something that people get really excited about and go ask their doctor, like, I don't mind getting 3 cycles of durvalumab, if that will get me to non-operative management just without, right? That will be.
Yeah, so that was perfect. That's where I wanted to go with this. So all of these patients had surgery.
Yeah.
And all of the patients in GI-002 had surgery. And we were looking at a pathologic complete response endpoint in these trials. If we look at other cancers like lung cancer, lung adenocarcinoma included, the standard of care if someone cannot have surgery is giving chemotherapy and radiation. And then once they finish that, we give durvalumab, the same medicine in this study. And updated results were presented at this ASCO, and they presented at almost every major meeting for the past 2 to 3 years. We're really seeing unprecedented survival rates in patients with advanced lung cancer. So we may see a difference with organ preservation. Immunotherapy may not change pathologic complete response, but it may do something else systemically to improve survival or improve, even if we don't see an early pathologic complete response, we may see a sustained local response in the rectum that facilitates a surgery later or an organ preservation approach. I think that comes down to the end point of interest and what you're trying to see in the trial. I think the other areas that are interesting, if you select for mismatch repair deficient, I think you'll really boost path responses. And there may be, oh, please go ahead.
Sorry, I was thinking that out of the 20, if none were MSI high, then this would be significantly more interesting, right?
Yeah, it could be.
Yeah.
I agree with that.
I'm like not happy that they didn't put that in the table.
I would have loved to see it because they have the data.
Yeah.
I mean, they tell us right here that they did it. They checked it.
Yeah.
But it's not here.
Yeah.
Maybe it's in the abstract. We have to check the abstract. Maybe it is there.
I thought that
Not
like
in
we
the
had this
abstract.
discussed. So what was interesting was that whatever was in the abstract, they put it in the poster. So it's just identical. So
Yeah, it's not in the abstract. I looked.
It's like they're, they really want our attention.
They sure do. They had us read every single word looking for it.
Yeah. I mean, I had not paid attention to this, so it's good that you amplified it. You zoomed in on to show that they did actually test MMR pathway. So
yeah,
I mean, and they're not telling us. Maybe it's good to email them. I mean, I don't know where they are. It's a European study.
I think it's Italian. If I
okay.
Yeah, it's Italy.
So going forward, do you think that immunotherapy will be an option for rectal cancer?
Well, it will be an option, and it is currently an option, most specifically for those with a mismatched repair deficient tumor or microsatellite instability high tumor that indicates response to immunotherapy. What we don't know is if there are other subgroups of patients that may also derive a benefit. And we don't know if the sequence of therapy and types of local therapy that they receive may have an impact upon response to immunotherapy. And
long-term side effects, the long-term survival that still is very new to assess that, right?
And I was kind of wondering that in the same format, if they now had, following this, they would, I mean, I don't know if they'd have like a way to estimate whether anybody had complete clinical response. And then, the next round will be 4 months of chemo and see if whatever, 5 out of 20, if they could increase it to like significantly more, and that would be kind of cool to see.
I would
if
love
that
to
would-
see that.
Yeah,
I would love to see that.
that'd be a nice study.
And there is a suggestion that dose per radiation treatment fraction, dose per day, has an impact upon immunologic response. A little bit higher dose per day may have more impact on the immune system. And so short course radiation therapy gives higher dose per day. That could be used as part of an immunotherapy strategy and could theoretically have more of a response. So I think those are kind of questions in my mind about how to use immunotherapy.
Yeah, that'd be
But
cool.
I think it's exciting. A lot of opportunity.
Yeah, so I'll email you. We certainly want you back. And
Yeah, I'd love to come back.